Welcome to Speak Up with Laurel Libby. We are so glad to be here today with Dr. Zev Myerowitz. But before I introduce him, I'll just remind you, please do go ahead and subscribe to the Speak Up with Laurel Libby podcast so you don't miss a single episode. Jumping right in, I want to talk about our incredible guest today. Dr. Zev Myerowitz Jr. is a chiropractor, Chief Medical Officer of Helios Integrative Health, and co-founder of Cape Integrative Health, one of New England's largest integrative musculoskeletal clinics. He is widely recognized for advancing a diagnosis-first, systems-based model of care that helps providers get beyond symptom chasing and closer to the actual source of pain and dysfunction. As an active release technique lead instructor and curriculum developer, a competitive triathlete, a seasoned clinician, husband, and father, Dr. Myerowitz sits at the intersection of clinical innovation, provider education, and patient outcomes. His work is centered on redefining musculoskeletal care through precision diagnosis, multidisciplinary collaboration, and a standard of care built to actually solve problems. Welcome to the podcast, Zev. We are so excited to have you today.
I am very excited to be here.
So first of all, we have to talk a little bit about you, how you got here. Tell us, you're not a first-generation chiropractor here. Tell us a little bit about that family history.
Yeah, so my late grandfather grew up in New York City and was diagnosed with a condition that he was losing his eyesight, and the medical system at the time.
How old?
About 10 years old.
10 years old.
About
okay.
10 years old, and it was slowly getting worse. He had glasses that kept getting thicker and thicker. And I believe around 12 years old, he had gone through the different hospital systems in Manhattan, and they couldn't figure out what was going on. And his mom at the time was told that he's just going to go blind, and that they need to learn how to deal with that. And out of an act of desperation, his mom had brought him to a local chiropractor, and at the time they were not licensed yet, and so it was very hush-hush. And the chiropractor was able to recognize some somatic dysfunction or joint interface issues in his neck, and started a treatment plan with him where he was adjusted regularly. And over the course of approximately 3 months, he went from being near blind to having full restoration of his vision.
Wow.
Until he was about 50, where he started to require readers again. But,
wow.
Certainly that is one of those miraculous cases that we hear about with you can have these mechanical issues that can have a visceral type effect. And, while that isn't necessarily something we see, every single day, those types of stories do occur. And that inspired him to go into the field. He practiced chiropractic for 71 years. He saw his last patient just after his 91st birthday.
Wow.
And, that one little intervention with him resulted in my father joining and becoming the first dual chiropractor and acupuncturist in the state of Maine, and I have two other brothers that are chiropractors as well.
It's all in the family.
It's all in the family. Yeah, makes that the holiday conversation is somewhat anticipated.
Yes, yeah. Talk business a little bit,
That's
huh?
right. Yep.
I have to say here, the hero in this story, though, your great grandmother sounds like an incredible woman.
Yeah.
She's like, we're not going down without a fight.
That's right.
We're going to figure this out.
That's exactly right. The credit to ultimately so many of these stories are, patients can always hear people talk to them about evidence-based or best practices and things along those lines. And it's important to keep those perspectives. But, when your child is dying or losing a significant side, you will do anything and everything that you can to help that child.
100%. I identify with that mama bear.
Yes. No, be very scared of the motivated mama bear.
Absolutely. Absolutely. So that's pretty cool. You got this family history. Do you work with any of your, siblings at this point?
Just at a professional advocacy level. I think watching family dynamics with my dad and my grandfather practicing together and everything that they accomplished and all the magic that is in a family business,
Sure.
I very much felt that I had to make my own path. And so, and as much as I enjoy the greater Bangor area, I really felt that there was an opportunity to establish in the Portland area. And so I have ongoing advocacy work on behalf of the Maine Chiropractic Association. I'm the immediate past president. I did about a 10-year executive committee tenure. One of my brothers was the immediate past president. So him and
So you've been in Augusta a lot.
A lot. There are a lot. It's amazing how far along AI has gotten with Google, because I Googled myself and actually
Never do
told
that.
me, it had a list of every bill that I've testified on over the last few years and the summation of my testimony. And I was like, I don't even remember that one, but that was a while ago.
AI's got it all in there.
It's got it all in there. So, I still have ongoing work as the immediate past president. One of my other brothers still sits on the board. So our professional collaboration is on behalf of the profession, advocating for patient access to care, patient rights, insurance reform, things along those lines. Yep.
That's awesome. So tell me though, I want to dive into the personal side a little bit here. You're a husband and a dad, and you are an athlete. You're a triathlete. So tell us a little bit about that. I have to be honest, I love seeing, a practitioner who very much practices what they preach. And so what does that look like for you?
Yeah. So, we, in the professional space, it's always about trying to optimize human functions, and most of that time it's improvement of range of motion, cessation of pain, restoration of activities of daily living. I have this thing I can't do, and I want to get there.
Yeah.
And at the ultimate end of that is performance and capacity. And so that's always been an area that I've been really passionate about. I've basically not stopped moving since I was 5 years old. And for the last 16 years, this is my 17th year competing in triathlon. It's a great mix of three different sports. So we swim first, and then we immediately get out of the water and jump on our bikes, and then we bike for a certain distance. So my preferred distance is a half Ironman. We swim about 1.2 miles, then we bike another 56 miles, and then just to cap it off, you run a half marathon. So 13 more.
Just another 13 miles.
Yeah. Yep. And I enjoy that distance. It works well with my physiology, where I come from more of a team sport background. And so sustained power output, but the ability to also push the limit at times really works well. And it's been very fun. It's one of those, training is kind of like the Aesop fables with the crow and the pitcher, where,
oh, yes.
you put the pebble in to raise the water level so that when you need to take a drink, it's there for you. And fitness is very much like that. There isn't a single day that you see the return on the investment. It's an aggregate of effort over time. It's like climbing the mountain, particularly with aerobic fitness development. I mean, 15 years in, there's still slow progressive gains. And, in a world where, especially in the United States, so many conditions and so much of our healthcare system can be attributed to metabolic disease or mitochondrial dysfunction. I'm pushing that as far as I can in the performance space, because as Peter Attia had said, there's nothing that's a greater indicator of your longevity and your function later in life than VO2 max. And so working on your body's ability to metabolize oxygen and convert that to energy cleanly is something that's going to serve you in so many ways going forward.
Well, I've been a long-time runner since college. I started my freshman year of college, and I've been running off and on since, more on than off, but you have seasons for sure. And I definitely feel that in my 40s now. I go, this is something I definitely want to keep up and continue, because I can see, there's a downward spiral if you don't continue to.
The maintenance on these models, they do seem to, the intervals tighten up a little bit, and if you ignore it, there's repercussions.
Absolutely.
Yeah.
So obviously, with a long history in the medical field and chiropractic, as your family has, you kind of knew what you were getting into. So what has inspired you to go in the direction that you have? As you look at medicine more broadly, what inspired you to go where you have?
So a lot of it comes from the foundational principles of what was kind of my life experience. I played a lot of sports growing up, and as with all kids, I probably treated my body as somewhat expendable, and would generally have no issues about making the diving play to try to get the ball and putting yourself out there. And, sometimes there'd be bumps and bruises and injuries along the ways. And I didn't realize the resource I had at the time in having family members that could put me back together. And so my life experience was that if
Dad can fix it.
Dad can fix it.
Dad can fix it.
And at home, it was very convenient.
Very convenient.
If I took a fall and I had a ripper of a headache the next day, and sometimes that wouldn't go away, or I injured my back and I had what I now know is facet-mediated pain, so pain coming from the back of my spine, I would just ask for help and it would be taken away like it was, like an error on a chalkboard. We just rub that out and
boy,
we're
that's
good to
dangerous.
go. It sure is, and it wasn't until later in life, even in high school, that I had teammates that would have similar injuries and didn't have those resources, and I would see them be out for a month or two, and then it only takes one or two of those rounds where you've lost the fitness and you can't catch up, and then that person's now really not able to contribute to the team the same way. And so I got really fascinated with pain because at the time we were still dealing with some of the political issues in the Maine, the medical associations not feeling that chiropractors were legitimate, and that all was some political issues related to the attempted monopolization of healthcare. And so, I was told even as a kid that what my dad and my grandfather did wasn't real medicine, and that they were quacks, and
yet your experience comparing you and your teammates.
Yeah, my real world experience about what I would go through, like, you can share with me that my reality isn't real, but I would strongly disagree with you, and I'm a bit of a fighter, and so that created a deep sense of recognition that we had something that was special, that was unique, and that was worth pursuing. And so in my graduate studies, I worked a lot in the VA hospital system, working with chronic pain. I remember doing rotations in the Monroe Community Hospital outside of Buffalo, and we would be working with people that had like hemivertebra. They were born with congenital malformations and things where the spine was structurally unstable, very complicated cases, fusions, having to work above and below those areas. And I remember just recognizing that even within the chiropractic system, while we were getting really good outcomes, a lot of the times the pain would persist, and I always was in a position where I was able to believe my patients. I'm here. These patients have no interest to lie to me. I'm not going to put them on disability. I'm not going to give them an opioid. I'm not going to do anything that would motivate them to be disingenuous. They're here. They're spending their time. They're spending their resources. They're trying to get help. And so if a patient was describing a pain pattern or a pain symptom that didn't match up to what I was taught in school, maybe instead of being in a position where I would then have to evaluate if this patient was being untruthful, I was always able to start from a place of, I believe you. This doesn't quite match the models that we're looking at. We need to go further and find out what's happening.
Figure out why. Get to the root of it.
And so at the same time, I was pursuing a second degree in acupuncture and Oriental medicine. And a lot of the times that would provide answers and using a different system of analysis that made sense. And we were able to get results where a single specialty didn't, as with all things, if you're a hammer, everything's a nail.
Right.
Right? Until you're not.
Yes.
And so
if it looks like a horse, don't look for a zebra.
Exactly. Yeah.
But you're like, there are occasional zebras.
100%.
Yeah.
And there's the occasional zebra up front and then the horse in the back.
Yeah.
and it can go every which way. And so that led me down a rabbit hole of really focusing on pain and function, and also recognizing that even within those specialties, patients would have greater outcomes when we would synergize together and working with more specialties that would help address the different elements of what would take a patient from chronic pain to full function. And so our initial office in Cape Elizabeth was opened in 2012, and we got the biggest space that we thought we could possibly need to occupy in 5 years. And in 2, we were running out of room.
Man. It's a
And
good
so
problem to have.
Good problems to have.
Very good problem.
And so in 2014, we had purchased a parcel near about a mile and a half down the road, and we built a 7,000 square foot facility that we moved into in 2017. And at that time, we added physical therapy. And because we recognize that the need to progress these patients just from the progression of acute pain to then loading and adding functionality to follow that, was just good standard of practice.
And different. I mean, I'm married to a physical therapist, and you'll see, kind of one or the other, and not so much this integration. But so much of what you do is outside of kind of the traditional box, and we'll get to talking about certainly government and insurance and all of that. But that kind of marriage of multimodal.
Yep. Multi-specialty care. So, yeah, you're absolutely right. Historically, chiropractors and physical therapists have been kind of
there's a little headbutting there.
I'll use the word oppositional.
Okay.
And I think the reality is that both groups have very good intentions and very good perspectives, but generally different means to get there.
Sure.
And the key goal for us was recognizing when each of us is going to be able to get the patient where they need to go in the most effective fashion. And we've been able to really develop a lot of intellectual property on best practices, best case outcomes. And so that patient could be originating from a variety of different sources, the natural evolution. So post surgery, orthopedic care. I mean, that really is best done by our physical therapy team. But what happens when a patient has a chronic tension headache that we're able to resolve, but then after 3 or 4 months of going back to work, that those symptoms slowly return. And so, if there's a underlying pattern where the patient's moving in a way to create the problem, then the need for rehab to help reinforce those strategies so that they can then recognize what they're doing to create the issue, that's usually best done by our physical therapy team as well. We have a tremendous group.
Yeah, I have to say, I mentioned I am married to a physical therapist, and I joke that I haven't had to actually pay for physical therapy, which I used to as a runner. I used to, be in and out of PT regularly during college. But since we got married, I haven't had to, see a physical therapist, but I do see a chiropractor. And so I totally understand the benefits of both pieces of that care kind of coming together.
Yeah. And I think the key again is always what is best for the patient and making sure that you act accordingly. And I like to laugh, we all have big egos because we're passionate about what we're doing and we're all confident in our abilities to doing it. But if it would take the chiropractor 3 visits and the physical therapist 6 and the benefits are the same, then we kind of have a good pathway on how to best manage this case, and vice versa, and often, insurance has a little bit of a contribution because the benefits can vary a little bit on, some plans, PT's a deductible, some plans it's the opposite with chiropractic. And if both have a good opportunity to help the patient, then we can kind of pivot within the insurance benefits to help them as well. And again, it sometimes they both have equal opportunities, and it's as long as you have a clear plan and we're having documented progress and good outcomes and good improvement, with a progression towards independence and autonomy, I think we're all happy, patients happy.
Yeah, you talk a little bit about insurance and kind of how that can be helpful, but there's also this piece of things where you have government intervention, whether we're talking about federal or state, both, and the insurance industry, which are turning into more and more of the drivers behind what patients can access. And we're seeing this surge of direct primary care, certainly here in Maine, practices, and your practice is a little outside the box. Can you speak to direct primary care and the practices that may or may not look like yours, maybe a little bit different, but moving outside of that perhaps traditional model to something different that is patient-centered, because that's what you guys are all about, is this patient-centered. How do we go from where we are to a truly patient-centered model?
So I'm gonna answer that question, but in 3 parts.
Okay.
So
well, it's a big question.
It is. So Maine's it's a fascinating state because as CMO for the Helios Group, we have about under LOI, we have 9 offices currently. We have a couple under development in 4 different states, and so the markets can vary a lot. And just the social habits can vary a lot depending on the states and the markets that you're in. But Maine is a really interesting state because insofar as you want to think of things as being covered, I'm going to use the words covered with parentheses.
Sure.
From a health insurance perspective, anyone who has health insurance has the perceived ability to access care. Okay. And
yeah, perceived. I think that's a really important word, perceived.
It's really important. It's perceived because if a lot of the benefits in the state, I would say, are considered ghost benefits. So what we've seen over the last decade, let's just take chiropractic for a second. I will come back to direct primary care on this. But one of the most common things that we see in today's age in the healthcare space is that a patient might have a $50 or $75 copay now to see a specialist such as a chiropractor. And most of the time, a chiropractic service with most major payers is going to be less than the copay is. And so the patients, on top of these ever-increasing premiums that we're seeing that are financially crippling our country, we're now seeing patients also bear the responsibility for the entirety of their care. And so unless you're in a major injury or in a major hospital stay or require some kind of medication that actually is truly expensive, not actually is truly expensive to make.
Yes.
Not costs a lot.
Yeah.
There is a
but
difference.
Actually
is exquisitely expensive to make. Then the majority of the majority of the financial responsibility is always on the patient. And so in specialty care, we haven't quite been able to navigate our way around that. The physical therapists are, I'd say, I think I heard a statistic from one of the local physical therapy schools that 90% of new graduates are going into cash-driven systems because they just cannot make the sources.
That's a remarkable statistic.
It's a terrifying statistic.
Into a cash-based. Holy cow, that's massive.
The sources and the uses of what you can reasonably generate on a per hour basis, seeing patients in a patient-centered way in the state of Maine with where our reimbursement is at, does not line up with the requirements of paying your rent, paying yourself something that can cover your student loans, paying your admin staff. It doesn't work.
Yep.
And a lot of that is because of the same reasons why the medical specialists all rolled up about 20 years ago, as they were experiencing the same financial pinch. And so because most chiropractors, physical therapists, acupuncturists, occupational therapists, anyone who's independent, they have no realistic bargaining capacity to negotiate with insurance companies to have even just a cost of living adjustment.
Sure.
Most of the major payers haven't, as I can state that on behalf of the Chiropractic Association, there hasn't been a major payer increase since before 2010.
Hasn't been a major payer increase since before 2010, but then we also have this phenomenon in Maine where a third of our population is on Maine care.
Absolutely.
And so then you're negotiating with the government, and I'm sorry, but that's probably, that's even a tougher lift because you're trying to get the legislature to vote you, appropriate payment.
Yep. So Maine care is exceedingly difficult to work with because the reimbursement is below Medicare, which is considered kind of the financial floor of the model. And there's just a lot of interactive behaviors with that patient population that makes it very difficult for you to wear your altruistic hat. So my brothers who participated with Maine Care for a long time because they felt that it was important to help that population. They were the first office for that you would get to from Washington County.
Wow.
Had to go all the way through Washington County, through Ellsworth, all the way to Penobscot County to get to them. And patients that were traveling from Washington County were getting reimbursed for getting travel reimbursement that was greater than the provider was getting to render the service.
Wow.
And, so again, it's one of those scenarios where it's important to help people. We got into this business to be of service, but when we're in a position where we're actively losing money to see these populations, you can't do that.
Right.
It is a business. It's not a charity. We have to be able to cover our life expenses to be able to perform the service. And ultimately, that's why you're seeing more and more providers have to pull out of network of these systems. It's just not financially feasible.
No, I mean, and the fact is that when folks do take Maine Care, I mean, it is a fact that insurance payments are subsidizing, insurance or cash payees are subsidizing that Maine Care payment because the reimbursement rate is so low.
Yep.
that is how the system currently is constructed.
Yep. So to come back
Sure.
to direct primary care. So, in the primary care model, because of this erosion of compensation on a fee-for-service model, we reached a point where any kind of infrastructure system, so a large primary care collaboration, because the costs to work with insurance, in addition to the reducing reimbursement, you have all of these hurdles you have to go to just do your job. You have prior authorizations, which I believe now is estimated to take up almost 30% of a primary care provider's time, is just sitting on the phone trying to get this medication approved.
That bureaucracy, just trying to get approved. The treatment that you know best, you know what the patient needs, but you have to sit there and jump through these hoops to get it approved so it can be paid for.
So I'm going to placehold that.
Yeah.
That's a real problem that we have in this space. But because the primary care model would require these providers to have panels of 2,000, 2,500, 3,000 people, and the math would work out that these providers would have to see a patient every 8 to 10 minutes just to be able to generate the dollars to be able to keep the business moving. It just doesn't work. We can't have a meaningful conversation where I go through your entire health history, every medication you're on, do a full systems review, and come up with a collaborative, comprehensive plan to help you in 8 minutes.
No.
It just doesn't work. And so the primary care model, the direct primary care model, was kind of born out of necessity from that, where the providers that were really passionate about their patients, the patients know. They know when you actually care. A lot of them were like, I cannot work this job the way it's meant to be done within these parameters, so I'm not going to.
Yeah.
And so we've seen a surge of direct primary care practices within Maine where these providers can act independently, have a panel of 250 to 500 people, anywhere between a tenth and a fourth of what they had to manage within the insurance model, and just be on a subscription basis. And they're there when you need them, and they're not when you don't. And when you have those kinds of models, you can now bypass all of the insurance hoops required to get that reimbursement. If I were to be your primary care provider, which I am not, but just from a discussion purpose, if you had an issue with what you were feeling, in a fee-for-service model, you have to be in my office. We can't talk on the phone. You have to be in the office. I have to check your vitals. I have to check your blood pressure. I have to do all of these.
To jump through all of the hoops
just
that are
to get the reduced
required
reimbursement.
for the reimbursement.
And so as opposed to us just having a conversation, hey, what's going on? Or whether that's text message or cell phone or all of the technology that we have, I'm feeling this way. And you go through those symptoms and 80 to 90% of the time that these issues can be resolved just by communicating as humans, as opposed to necessarily looking at you. And certainly the cases that require exams are a little more alarming. No, I need you to be in here. Let's check your vitals, do some rapid testing. Let's see what's going on here. Versus, my child's having an earache. What do I do here? What are the first options? And being able to give patients options to help them navigate the issues with early intervention versus letting it marinate while we're waiting for that appointment. And now all of a sudden we're in a far worse place than we would be. We're avoiding unnecessary cost. We're solving the patient's problems with early intervention, resulting in lower care, lower cost of care.
Well, and I think that's important to note, because when you're talking about, these are subscription service usually is the fee model. And so folks go like, oh, maybe you're paying for insurance at the same time just to have that backup, but and then subscription on top of it. But if you weigh in the balance, the unavailability of the traditional and then, a couple visits to urgent care, the math suddenly starts to make sense.
Oh, 100%. I mean, 2 urgent care visits, you're breaking even for the year.
Right there.
And if you have, I have 4 children. You have you have similar sized family, 5.
Yes,
right? 5.
5.
Yeah. And the inevitability of
Somebody
having to make
is
it to an
always
urgent
doing
care.
something
Yes.
dumb.
Yeah. It's not if, it's just when. And so the math works out for a lot of people for you to be able to say, okay, I'm going to budget this resource towards making sure that my medical needs on a non-emergency room basis, like you break your femur, you need to have a reduction. That's a completely different discussion. But
Totally.
the 99% of the things that we need can be managed in a clean access, fastidious method at a very manageable cost. And I think that's just why we're seeing such a bloom of this particular model. And I'm fully in support of that. We have urgent care services in our Cape Integrative Health location, but I still use a DBC for my kids because it's just easier.
Absolutely.
It's just easier. A text message basis. We love our provider, very accessible, and you again, you get your problem addressed quickly and reasonably.
So what are you seeing in your practice? Somebody comes in and maybe they've been fighting with the traditional system, getting nowhere, have an issue that's been going on for a long time. Like these musculoskeletal issues are some of the most common reasons that people need to see a provider, and yet perhaps are some of the ones that you tell me kind of linger and aren't treated perhaps as they should be. What are you seeing in your practice?
Yeah, so over 50% of all reasons why a patient will see a healthcare provider is because of pain, particularly musculoskeletal pain. And so it's the
So they're going to their primary care doc saying, I've got a pain in my knee.
My neck hurts, my shoulder hurts, my back hurts.
Okay.
It's keeping me from doing X.
Yes.
Okay. And primary care, you really have to think of them as the quarterback. They are the ones who are reading the field to help direct the play, but it's very reactive. And how do I help navigate this problem that you have? And they have so much diagnostic and management work that they have to do that there's just no meaningful way that they can develop the specialties to manage these musculoskeletal injuries personally. It's just not what they do. They don't have the advanced orthopedic training and intervention to also determine what kind of problem this likely is and how to best manage that.
So you're saying like a lot of these problems that people are going in with, like there shouldn't even be an expectation that that's who's going to fix the issue.
Yeah, the primary care provider will never be the person that's going to fix your sciatica personally with their hands.
And yet anecdotally as a nurse, for a long time, I'd hear that complaint. I've been seeing my doctor for this, this issue for a long time. It's still not better.
Right. And so, if I'm working with my PCP and we're going through all these imaging, like those systems are not efficient. You have the appointment. Let's say you're having sciatic pain with running, for example. Okay, well, let's do a screening X-ray to see what's happening. You got to schedule that appointment. It's going to take a week or two. You're still hurting. You're not able to train. You come back. The imaging's negative. Well, let's send you to physical therapy. And then the physical therapists hopefully are going to be able to address the issue and take you there and move things forward. When that works, it's great. It works really well. But let's say this is a simple peripheral entrapment, like a carpal tunnel syndrome. The advanced soft tissue diagnostic work, it's much less common than you might think it is that providers have this training to be able to suss out exactly where the problem's coming from and then recognizing, is this an intervention that's going to do best with myofascial work either by a chiropractor or a physical therapist? Is this something that's truly spine related? Is this something that, based on your other factors, is more likely to be something that we might need to pull pain management in? And then actually being able to present, this is your problem, this is the most likely solution. If you don't respond to this, then this is plan B. And if you don't respond to this, then we need to go to plan C. And between B and C is when we want the MRI. Because I need that diagnostic resolution to determine if that's truly what the issue is. And so the going back to our clinical decision making, whenever you order a test, you have to be able to say it's going to verify what you're doing, or you're at a fork in the road and the test is going to tell you which way you need to go.
Sure.
And if the test isn't going to change what you're doing right now, then why are you doing it?
Then why are you doing the test?
Right.
Yeah.
And so having patients understand that roadmap is not just confidence inspiring, but it lets them know they have a plan. And so I would say that at Cape Integrative Health and at all of the other locations we have, that is the point. The point is what we call outcomes-based care, where we're recognizing exactly what the issue is. We're coming up with a clear plan on how to resolve that issue for you, and the most likely interventions that's going to create that. And most of the time, it's without a surgical intervention or having to resort to needles or things along those lines. But in the events that it's a little more complicated, having that advanced conversation about if we're not seeing obvious functional improvement by X time frame, then we need to then consider that this is actually what's limiting us, and we would then go to plan B or whatnot. And just that confidence, knowing that, the unknown factor, if you will, isn't based on our clinical capacity. It's just based on what truly is how your body's going to respond. I mean, that's not really a question of if we're going to get there. It's just which one's going to do it.
So all you've been describing makes me think of the contrast between healthcare, which is actually, that process of, I think, bringing someone to health, keeping someone healthy, preventative care even, and what I think our model is at, and that is crisis care, really, where whether it's ER or the jammed up practices where folks are trying to get in and see their provider for 8 minutes, the restrictions from insurance companies and what they can reimburse, that, we have government handing down mandates for what they have to cover. And so, everything is getting tightened up and more expensive. And it is this crisis care model as far as I can see. But what you're talking about truly does sound like healthcare.
The expression, an ounce of prevention is worth a pound of cure, if you will. Like so many, I think the system is inherently designed to try to shift problems towards becoming more expensive. And I think a lot of that, we have to take a real top-down view here. Insurance companies have a federal limitation on how much they can profit off of their premiums, okay? But so if I was a major insurance carrier, not going to state any names, would I rather manage $1 billion or $100 billion? Because the larger the pool of dollars I get to manage, the greater my profit opportunity is going to be.
Sure.
And so they're not actually incentivized to reduce the cost of healthcare beyond that which allows them to have their profit model.
Sure. And at the same time, you mentioned there are federal laws and guidelines around insurance. Then at the same time, during my time in the legislature, I hear this ad nauseum. Every session, there is a bill or multiple bills dictating what insurance must now cover, whether it is fertility care, which that was a recent mandate handed down by Maine state government. Every time that we add a mandate, that adds cost. And what I hear every time something like that gets passed is, well, it's just one. It's just one thing that has to get covered. Well, it's not just one thing that has to get covered when you add one and then another one and then another and another. And so all of these mandates, whether you're talking about the state level, federal level, all of these pieces add up to being a massive puzzle that is really expensive and doesn't, in the long run, benefit patients.
So I love that conversation. So let's just talk about the fertility component of it. Love the idea that we're providing services for people to potentially to make sure that we're allowing families to have babies. Because I think from a society, that's something that we one way or another, we're going to have to continue to have children.
Sure.
Otherwise, that's going to be bad.
We cease to be a civilization.
That's right. It's something that we need to support. And yet we're seeing ongoing reductions of fertility levels. It's been a trend that's been going on, to my knowledge, for at least 50 years. And we recognize that a lot of the environmental factors and societal factors and a lot of the things that are in our food are limiting are hurting us in the long run from a fertility perspective. So I think it's a lot less expensive to try to improve the quality of our lives through our diet, our nutrition, our exercise, trying to reduce the amount of phytoestrogens that we have in the area, that trying to reduce the microplastics that are causing upregulating of estrogen activity within females. There's all these different environmental factors that we are very aware of that are hurting our net fertility levels. If we're going to be in a position that we're having to support these families to make sure that their ability to conceive, and we're not paying attention to try to stop the problem at the very beginning, that really is a short-sighted intervention. And so,
well, that is crisis care, right? And it's just Band-Aiding over.
Yep.
You got this oozing wound that you're Band-Aiding over instead of getting to the root cause of it.
And so on our side, when somebody comes in certainly we often will see patients when they've gone to 5 or 6, 7 providers and no one's been able to help them. And if that patient was able to be helped by the first person they saw, then they would never end up in our office, and that's great.
Sure.
But the work that we do takes the anatomical resolution of what could be a pain generator for you as far as it can possibly go. Meaning that if a typical provider might be just diagnosing you with chronic back pain, and then a good physical therapist or osteopath or chiropractor would be able to break that down to whether this might be facet mediated or disc mediated, or if we have a particular arthritic spur. And then we're taking it to the level that, you had these problems 12 or 15 years ago, and that has been resolved, but the long-standing inflammation in the back has caused the muscles that stabilize your spine to scar up to the point that a particular nerve has become fascially tethered, and that's why it still hurts even though the MRI shows that the disc injury is healed, for example. And so being able to recognize that with that level of ability and precision, and then coming up with a plan to make that correction, this patient could have 3 or 4 more MRIs, a bunch of invasive injection procedures, and no one's able to exactly identify what the pain generator is. And so it really boils down to being very, very methodical and precise in what the exact pain generator is and how it got there. And at the healthcare system at large, we really would do better if we allowed providers to be proactive or incentivize them to be proactive early on to stop problems before they became big, expensive emergency room visits. Great example, $100 copay to see your primary care or your physical therapist or your chiropractor, or you have a $5,000 deductible. And so these patients have these financial barriers to access, but they know that if it's really bad and they go to the emergency room, they're going to get an intervention, and they may, like if you have a Medicare or a Maine care program, they have to take whatever it's going to pay,
Right.
whether you're financially going to pay for that bill or not, and so it's shifting more and more and more costs away from early prevention into the big expensive systems, which ultimately is just exacerbating the problem.
Yeah, and exacerbating the problem, and it looks at groups of people, right? And it doesn't look at the individual. And I mean, that's what matters to individual Mainers, individual Maine families, is that they can access care, that they can access good care, that they can access care that gets to the root of issues and is not just crisis care. And I think that a lot of folks are frustrated because that's not what our system is built for. And I think that's why we see direct primary care surging in our state, because people are frustrated with the status quo, with what is kind of prescribed as the solution, but isn't providing good care. And so we see the free market providing this solution that more and more patients and families are gravitating towards because it's not a Band-Aid. And you have longer than 8 minutes with your provider and can get to the root cause. So whether you're talking, about the practice that you guys have and that musculoskeletal component, or someone frustrated because, they can't get their kid in to see the pediatrician for 3 months. And then, like you say, that issue gets bigger and bigger until suddenly you're in urgent care or the ER instead of resolving it before it can get to that point. That's why we see, this direct practice model thriving. People are hungry for it.
It's absolutely the first and a very important step in the right direction, because when you have options between choosing an insurance-driven system where everything is inherently going to be more expensive because the providers, an insurance-driven facility is always going to charge the maximum allowed by any of their insurance plans. And so that's just how because you're getting lowballed on so many things that you do, that the things that there are margins on, you have to take advantage of, because that's the only way you're able to help the most people as a population. And so you have this insurance-driven system that is administratively cumbersome. I would estimate, just with our offices, what is the relative cost to be able to work within an insurance system? It probably doubles our fee.
Wow.
just to be able to accept the
Wow.
insurance and have the infrastructure required to be able to work within those systems.
Because you guys do, and
Mm-hmm.
I know, direct primary care, a lot of these practices don't. They
Right.
just are like, take it or leave it.
Yep.
We don't deal with insurance of any kind.
Yep. And so the
But to double, to say, ballpark
certainly
double.
doubles our costs just to be, and the patients that are paying cash have to carry that too, because I have to have the infrastructure.
Right.
It, it just is. It's
Yeah.
it's the
So
it's
it's
the
just
cost
the
of doing
cost.
business.
Yes.
And so we have to pass that downstream.
Mm-hmm.
And so the direct primary care models, you have these independent providers that have whole panels of patients that love them, that are just like, I want to be able to do right by you. I want to be able to take the time required to actually help solve your problems. And so therefore I'm going to limit my panel to the select ones that value that time as a resource.
Mm-hmm.
And we're completely bypassing every single entity that is incentivized to limit you from being able to seek the care that you want. And or is incentivized to delay a test to try to get you to give up, to be able to move your own care plan forward. And so what we're seeing in the world now is we're seeing a subset of these different offices that are providing this service at a lower cost, at a higher quality point of care, and we're letting the market dictate. I think patients need to remember that they are consumers. Okay? As a consumer, you have a choice in being able to dictate where you spend your time, your dollars, and your resources to get the care that you need. And I think we've shown that capitalism is always going to be more efficient than any government-driven entity. And so we're seeing a really interesting shift in the healthcare space where people are having to walk away from insurance-driven systems for anything other than catastrophic interventions. And I think that's a step in the right direction. The one problem that we have yet to solve is direct primary care does a great job for handling your primary care needs,
Sure.
which is important.
Yes.
Like it's a significant part of the healthcare continuum. But anytime that the requirement does require the management requires specialty or management to that, you just got a faster appointment to then get in line and wait for the same systems.
Yes.
And so,
but boy, don't you then see that contrast? I mean, like when you've gotten used to that direct primary care model, and you have to leap back into the vortex of all of the complications of what is now maybe traditional medicine.
I mean, just to compare it, like
what a mess.
When we travel, like I spend the additional dollars per year when I have to travel to teach for both TSA PreCheck and Clear.
Sure.
And every now and then. You pull that's not going to work for you today. Like I think every 10 or 20 flights, they intentionally don't give it to you as part of their algorithm. And the days you don't have it, you're like, oh, this is terrible.
Am I going to make my
How
flight?
did I function here? How did I live without this? And so, yes, we're seeing that compare and contrast when, let's take, endocrine or rheumatology or cardiac in the Portland area. I mean, you're 6 months. Neuro is 6 months to a year right now.
And if you need to see a neurologist, it's for a reason. I mean, like, it's not like you're going to any of these specialties because you just, let's look into it, see if something is there. No, if you're seeing one of these specialists, it's because you need to. And so to have a 6 month to a year wait, I mean, but we're short providers, not just in the specialties, but across the board in Maine. We do not have enough medical providers. And I know the solution from Augusta is, incentivize in a variety of ways. None of them have proved productive. We still have shortages. What do you see as the solution that is going to incentivize folks to practice in Maine, but to practice at all? I think that it's hard to say, you should be in medicine when there's such a bureaucracy and providers are they're burning out at incredible rates.
So I'm really glad you asked me that question. There are two things in particular that have to change. Right now, in the insurance network, we have a separation of the insurer themselves separate out denials as being away from medical decision making. And because of that, it theoretically absolves them of the liability of denying medical care. The stipulation is that because they're not medical doctors and this is an economic reason or an algorithm, it's not actually medical decision making, and therefore they're not liable for that. If at a state or a federal level, we eliminate their ability to perform those unnecessary denials without bearing the responsibility of medical decision making, it's then going to quickly rectify the unnecessary costs of care that are due to the system becoming more expensive because we are intentionally denying patients from having access to the tests they need, that then exacerbate the condition, that then results in more expensive care, damages. If we allow that system to self-correct, then we're going to see insurances actually start to then be financially a little bit more aligned with getting the patients what they need quickly to solve the problem. That's the first major system that has to happen at a federal level. The next thing that has to happen is that we have to stop putting patient health and health of our population on one side of the table and shareholders on the other side of the table. There just isn't going to be a scenario where the shareholders of United, for example, or the shareholders of any major insurance company have a agenda or a goal that is disincentivized with the policyholders of that same insurance company. We can't, as a population, as a society, we can't hold people and their healthcare needs as being less important than the profit of another entity. We can't, and currently, because the system allows for that to happen, healthcare insurance companies take advantage of a lot of healthcare providers' inner sense of altruism. We didn't do this to just make as much money as possible. We would go into hedge funds or finance or things that
you would not go into medicine.
We would
if you
not go
to
into
get
medicine
wealthy.
if the goal was to make as much money as possible with as little effort as possible.
Well, I think, isn't direct primary care the where you can see this the most clearly? The success of the business is dependent on the success of the patient care. These are absolutely interwoven pieces here. If a patient is not happy with the care that they're getting, they're going to leave, and that business is going to fail.
Yep.
And so it is absolutely incumbent on that practice to make sure that their patients are happy with their care, that they are getting to the root of the issue, that they're getting quality care, because their practice won't survive if they're not. And so that separation you're talking about is really tremendously harmful to healthcare, turning it into crisis care.
Yep. So a couple really good examples of that. People generally think of, so as a chiropractor, people generally think of my work on a day-to-day basis as being primarily like spine related or back pain.
Sure.
And I can
just cracking people all day.
Right. And I can say that certainly the majority of the cases that I work on have nothing to do with the spine. It's like chronic foot pain or ankle pain or intractable tension headaches, or I really focus on the things that are non-responsive to most interventions in the healthcare system. But a lot of the times that patients will come in because we were able to solve that issue for them, and they'll just bring in something else that may or may not be what we do, but they're just looking for that triage of pain.
Yeah.
And
they want the same thing, regardless of whether it's a musculoskeletal.
They want us to solve their problem.
Yeah.
They just want us to solve their problem. And if you can't, whether you're a primary care provider in a DBC or an insurance setting or a chiropractor or an osteopath, your job is to solve the patient's problem. Full stop. And if you can do that, whether you're the person that renders the treatment or not, if you can do that in an efficient, cost-effective, human connection approach, that patient is going to come back to you because you're providing them the service that they need in the most efficient manner and the most qualitative manner possible. And a really good example, I had a patient that I saw for just a standard musculoskeletal issue. No problem, very straightforward. this patient had a child who had a small blemish on the side of her face, close to her ear. Within the first few weeks of birth, started to get larger. Brought into the primary care provider because she was concerned, and I wasn't in the room. I can't make assumptions, but the feedback was that it wasn't something to worry about. It wasn't a big deal. It was something that we could just watch and wait. And she was just telling me the story, just as sharing with what was happening. And the child was there, and I happened to take a look. And while I am certainly not a primary care provider, I do have some training. And in California, chiropractors are qualified to be PCP, so we have a lot of that basic training. But I also have children myself.
Sure.
And so just looking at this child, it was very obvious that individual had something that was called a hemangioma. Okay, it's a vascular malformation. Usually, it's not a big deal, but if it's getting larger, it's a big deal.
Sure.
And she showed me some pictures, and this thing had clearly tripled in size in a very short period of time. And that is if not a medical emergency, it's something that needs to be managed.
Yeah, usually as a parent, you're hearing this should disappear by about the time they're 3.
Yes. But it also shouldn't be getting bigger.
And it also shouldn't be getting bigger.
I very much said this, feels very emergent. We need to loop someone else in. And I contacted one of my colleagues who is a primary care provider and now does a DPC, and conferred with her that this is actually much more of an emergent issue. Sidestepped the problem, got them the care they needed. Had to go to Boston's Children's for management, multiple surgeries. Lots of complications because this was probably delayed more than it should have been.
Wow.
And it's just another good example of being a good healthcare provider requires knowing exactly when something's in your lane, and even if it's not in your lane, when it needs to be expedited.
Yeah.
You don't
have to know everything, but you do need to know who to loop in.
Yes,
and when to loop them in,
and quickly. You know, and there's just so many cases like that where, even if it's not something that we have to directly fix with our hands, we know exactly where it needs to go and why. Just conversational ones about. I was seeing another patient for a shoulder issue. Had just got done hiking the Appalachian Trail, and during the exam, I saw like some abnormal skin appearances, and I started asking questions about it, and then patient showed me that, I thought it was like pack rash, and upon further scrutiny, like acute cellulitis, like probably a spider bite, like medical emergency spreading across the body. You're seeing all the signs in the venous malformation of actual vasculitis, and I'm like, this needs to, you need IV antibiotics like now, and that there's those kinds of cases where, our job is to solve the patient's problem, whether that's us or where it needs to go. And I think that's why we're seeing the direct primary care sprout up, or why we're having the success where we're working, is because even when it's outside our lane, we can quickly recognize and triage.
So I'm going to ask you the last question. It's the biggest question of them all. Give me your take. Where do we go from here? How do we fix healthcare in America today? And I told you that's the biggest question. But that saying, "How do you eat an elephant one bite at a time?" I think that certainly applies here. So, what do you think? What is the long-term solution? I know what I think the long-term solution is not, and that is not for government to be 100% overseeing healthcare. We hear the left driving towards single payer, meaning taxpayer funded healthcare, which is terrifying to me on so many levels as a nurse, as a mom, to see the complete incompetence now of any of the, whether you're talking about Maine care, but any of the government managed portions of healthcare are abysmal. But the answer to fix that is supposed to be that we need more government involved, and then they'll be able to do a better job.
Yeah. So there isn't an example that I can think of that the government can do a more efficient job than the marketplace in managing a population-wide problem. And after over a decade of legislative work in Augusta, the incumbents at B on any side of the aisle, any particular single payer model is going to face the same issues that we're having now, but at a much larger scale. I was just laughing about this when I was debriefing some of the legislative work with one of my siblings, and I feel like for the last 15 years we've been sitting on the no man's land of a World War II front, where for all the efforts and all the energy that we put out, it really is just a game of the line moving a few inches one way or another.
Yes.
And because healthcare is a business, and because a lot of providers are expanding the scopes of what they do, I mean, we have certified registered nurse anesthetists competing with the actual anesthesiologists. We have PAs and nurse practitioners competing with physicians. We have physical therapists,
Competing with, but still not enough.
100%.
It's remarkable.
And so we have a scenario where there's a massive shortage of providers, and yet we're still fighting over turf. And saying that this person isn't qualified because of X, Y, and Z, despite their own licensing board saying that they have the appropriate training for this.
Sure.
So I'm illustrating all of this because I don't think that we're going to find a fee-for-service insurance national payer-driven system that's going to solve the problem, because it inherently is carrying. It's like cloning a virus-riddled system to a new computer.
Yes.
Like the problems are still inherently there, and so short of a complete reboot, we're going to see radical shakeups in the marketplace, like DPC type movements or fee for service or subscription based type specialists, and moving to that model, because we're going to have to, as a healthcare at large, where the market is going to shift based on the consumer demand and the need. And as long as we do that in a way that doesn't necessarily convey antitrust or monopoly, the capitalism is going to provide a better solution. And so as long as we, as a legislative entity, allow those systems to happen, I believe that in 10 or 15 years, we're going to have a system base where patients are going to be, whether it's through AI, be more informed about the kinds of problems that they're having and be able to help self-advocate or self-triage, at least where they need to go. And then being able to access those systems where the providers can work directly with them, in a DPC or a similar model to what we're doing, and having that access at a reasonable cost without having to pay a 4X or a 10X fee just to have the administrative checkbox. So I do think that we're going to see a major shift where the oligarchs that is the current insurance market are going to start losing market share, because the market cannot sustain where we're going. I mean, even, we're considered a large employer at this point, and we're still seeing 15 and 20% premium increases annually. I mean, that's not sustainable.
No, it's not.
And on the bottom end, we're not seeing that as providers.
Right.
Our reimbursement is flat. And so, you can't, the line has continued to narrow and narrow and narrow, where just through inflation and cost of living with taking care of your staff, that same fee for service is now going less far. It's shorter and shorter and shorter, to a point that, unless, only as I said, only the providers that are incumbent have been practicing and already have that established entity are able to still make sources and uses line up. And so that's why we're seeing so many new graduates. They're like, I can't make this work. I can't, I can't run a loss for 10 years to then get to the point that I can barely break even. So I'm not going to, and so we are seeing a pretty rapid shift in the marketplace. And so healthcare as it is right now is not going to be how it is in 10 years. And it's definitely not going to be how it is in 20.
Well, that's exciting to me, because that means maybe we will be shifting with the free market involved to what might actually be able to be considered healthcare instead of the current crisis care. One other piece that I think comes up more and more nowadays, we're seeing AI when we're hearing that AI is going to take over the world and take everyone's jobs. Where is the interplay for you guys with AI and medicine?
So it's interesting. It's coming along. So as we speak right now, just to give some perspective. So AI is very good at doing certain administrative repetitive use tasks when put in certain parameters. So it's fast, but it's not as intelligent as we would think it is yet. It can't have context. So, AI-driven radiology programs are approximately at the level of first-year residents.
Okay.
That's where we are from. But that is significantly lower than a
they've
fellowship
seen
or an
one,
attending.
done one, but maybe they haven't taught one
Yes.
yet.
Yeah. So to give some relative perspective of accuracy, that's about 40% accurate.
Okay.
Where
So we're not
attendings are
handing
90.
off yet.
No, so there are certain functionalities that it works quite well. So tracking blood work and trends and parameters like that seems to be, there's a lot of opportunity in expediting care in AI-driven models that way. Anything that is really quantitative.
Okay.
Yes, no, if I have all these symptoms, what are my potential differentials and what are the triages to run through that? Like that kind of work works well. When it comes to qualitative, functional, or movement-based issues, it's not there because the resolution of the diagnostic testing that we have isn't there. And so there is an entire subcategory of pain. We'll call it neurodynamic. Where you can have fascial issues within nervous structures that can limit your ability to move within a range or can be pain generators, but they're not so severe that they can be measured in a needle EMG test or a nerve conductance velocity test. And you can't quantify nerve inflammation in an MRI unless it's really bad, like 9 out of 10 or 10 out of 10 bad. And so because of that limitation, we can't put those into large language models to be able to recognize functional pathology yet. The bleeding edge for that is something called advanced elastography, where we're using ultrasound transducers and seeing if we can see soft tissue changes or fascial density changes and working back from there. But it's still very early. Even the research in quantifying how much fascia plays a role in our sense of proprioception, our sense of where we are in space, and its role in functional movement it's early days.
So at this point, AI can really help a patient maybe drive what they need to look at, what they need to ask their provider about, where they might need to go next, what could be helpful, doing that broad research. But you're not out of a job yet.
No, I'm not convinced that I'm going to be out of a job in my lifetime. I don't think that we're going to be there because one of the most exciting things about the research in this space is, we're beyond the point. So providers and providers that have a lot of manual skill, a lot of palpation-based skill, when we're combining orthopedic exam with functional palpation, providers of multi-specialty, whether or not it's physical therapy, chiropractors, orthopedists, we all can feel these structural changes, but we're not actually as far along as we think we are in what it is we're actually feeling. Are we feeling density changes or tension within the system? Or are we actually feeling like piezoelectric responses? So what research is trying to catch up with right now is actually matching what providers are feeling to what that actually is so that we can scientifically repeat that outside of the human experience. Okay. And so once we start to identify what those structures are, there's a few well-known researchers in the area that are really pushing this. We're looking with a couple of the chiropractic colleges in the area to try to help develop some research to exactly what this is, and most likely with advanced ultrasound application. Once we start to quantify what those things are, I think that then there'll be some potential for technology development, but we're quite a ways. We're a ways away from that. Yeah.
So in a way, AI is kind of exploiting how terrible medicine is right now, right? Because patients are desperate to get answers, and so they're looking wherever they can to kind of figure out. So somebody might be at a point where they've been to their PCP, they've had this issue for a long time, they're frustrated, and now AI exists, and you can put all your symptoms in there and kind of, what's my next step? And so, no, it's not replacing, but in a way, it's kind of going, well, I'm unable to get the answers that I want or that I need.
So large language models, AI, it's only expediting the shift and changes that we were talking about earlier, because it is impossible for an insurance-driven PCP to reasonably assess 10 years of lab tests and have a very skilled, informed plan reactive to that data and pushing things forward in 8 minutes. Like, the system doesn't allow the providers to do the qualitative analysis that they need to do for it to work within this sick-based model. And so large language models, patients have the rights to their own data. They can feed that into there and see what AI is giving feedback for trends and what that means. And even outside of what you would consider insurance-driven best practices and running that, for example, blood lipids. Like, there's been so much development in truly understanding what's happening from a pathomechanism with lipid profiles, not just good and bad cholesterol. There's multiple levels that are far deeper than that. And while the insurance models are starting to catch up, like, functional medicine is just so much farther ahead. And patients are at a point where they're just sick and tired of that whole process. They can feed their data into a large language model, and then the AI can give them that feedback on, this is what we're seeing. You need to coordinate with someone who does functional medicine or a direct primary care provider that actually has the time to work with you to evaluate this, or to go to more advanced testing that might not be covered from insurance but actually solves your problem.
Ask about X, Y, and Z.
Yes, exactly. And so, and in the functional movement space, you can describe what your symptoms are, and AI may give you a differential diagnosis of all the things that can create this, but all that's going to do is then recommend you seek a specialist in this area that can triage that out, such as, ourselves at Cape Integrative Health, certainly another skilled manual provider in another area. And so what we're actually seeing is AI is expediting this process because patients are recognizing that they're consumers, and this whole doctor-patient relationship of subservience, we historically have always treated healthcare providers as being an authority, and with all of the training and the knowledge that they had to have to get to the point that they were in the 70s and 80s and 90s, rightfully so. The system has eroded their ability to continue to be that authority in a lot of clinical settings. And so the ones that have moved to a DBC model are saying, no, I need the time required to do this right. I can't rush this. Technology is just pushing the consumer towards where they need to go.
So where can folks find you on social media?
So I'm Dr. Zev Myerowitz on Instagram. We have there's a Facebook page. I'm on LinkedIn, and then Cape Integrative Health has Instagram, Facebook, LinkedIn pages, and so does the Helios Group. So we're everywhere.
Awesome. To continue the conversation around direct primary care and the benefits therein, we have in the studio today joining us two nurse practitioners from Live Life Family Practice, Courtney Muldoon and Rachel Baillargeon. Thank you, ladies, so much for coming in today to talk about your practice and where healthcare is going in Maine, across the state and really across the country. So please, for our audience, introduce yourselves and let's dive right in.
So I'm Courtney Muldoon, owner of Live Life Family Practice out in South Paris. Great story, we are moving pretty soon to Poland, so I'll kind of talk about that after. But long story short, I've done healthcare. I've been in healthcare for, over at least 15 years now. Kind of started young and was a CNA, kind of worked myself up, was a nurse for a while, and just saw that corporate healthcare.
Corporate crisis care?
Yeah, corporate crisis care. Yep. A lot of Band-Aids in the medical world these days. So long story short, I worked in the ICU for a bit and realized like a lot of these patients live in rural Maine, right? I grew up in rural Maine as well, with difficulty with access to care, and saw that just as youth, right? So fast forward a few years, and a lot of patients were coming in with hypertension and strokes, and what was the reason? Why? They have high blood pressure. Okay, well, why aren't they on medication, or why aren't they being, treated correctly? They live in, Bethel, Maine, or they live, very rural. So there's not the access to healthcare. So fast forward, I went back to school and saw that there was a need, and got my master's in family medicine, and worked for corporate healthcare for a while. And love what I did, but that's all I knew. That was a rat race, and it was very busy all the time, fast paced. I just felt like people weren't heard and they weren't seen, and said I can't be, part of this. I need to do my own thing. So fast forward another few years, during COVID, said, here we go. Let's open up my own place. So we are out in South Paris. It's called Live Life Family Practice, and we do what's called direct primary care, and we can talk about that.
We'll definitely talk. We'll definitely talk about that.
So yeah,
but yeah, let's introduce Rachel as well.
Sure. So my name's Rachel Baillargeon, and I joined Courtney a couple of months ago at Live Life. My background is primarily in pediatrics and women's health. Grew up in Corinth, Maine, a small town in Penobscot County, and my family always was involved in going through well child checks, and we always had good access to medicine. I didn't really realize that was a problem until I became a provider myself. So
I think we all three kind of grew up in the heyday of like things were still going well in healthcare, and I mean our family, we always went to our well child appointments, and like it was just everything kind of was going along. And then over the past couple of decades, it has gotten harder and harder. And I advocate because of more and more government intrusion into healthcare. And the more that we have federal mandates and state mandates and the government kind of infringing in healthcare, the worse it's gotten, access and cost. And so you kind of grew up seeing access be normal, and then as you moved into practice yourself.
Yeah, I saw more and more patients have challenges with getting into primary care. I may see them in specialty areas, and by then their preventative medicine was lacking. So I had reached out to Courtney, had heard about her practice, and really got behind her mission of expanding access.
Yeah.
And recently we've seen there's been some articles in kind of the mainstream media, mainstream press talking about there was a practice that just opened in the Bangor area, and that was on the front page of, I think, the Bangor Daily News talking about this practice. We're seeing this type of healthcare practice expanding across Maine. Live Life Family Practice is definitely in good company with other practices opening. Talk to me about like what that practice looks like versus kind of the typical, right? I feel like we've kind of followed similar tracks. I went into politics, you went into direct primary care, but starting as a CNA and then working in practice and then working in the ICU, and here you are, hey, maybe you'll run for state rep someday.
Yeah, I know. That's a heavy topic. But anyways, so what we do is what's called direct primary care. So it's a monthly membership model, a little different than the typical insurance model. So we have a monthly fee for service. So it's, for us, everyone's a little bit different, but it's $100 a month or $1,100 for the year. And that covers all your acute visits, all your well child checks, all of your annual visits, 24/7 access to us, text, emails, calls. We try to get people in same day, next day, kind of like healthcare the way it should be. And that's our motto at Live Life.
It's like the modern equivalent of like the family doctor coming to your house with a little
Dr.
like
Quinn.
leather bag, right?
I always want to be her. I still do. That's what I aspire to, a horse. But I borrow one from my parents.
You don't have a horse
No,
that you can
dad
like
does.
ride to appointments?
I know. I'm like, I always wanted to be Dr. Quinn, so here we are. But yeah, so it's just it's a little different than regular traditional healthcare. Where you call, you might get an acute visit in a week or two, or told to go to an urgent care. And we try to really get our patients in, and we really get to know them. So it's a whole family dynamic. We see newborns to geriatrics and everyone in between. We dabble in a lot of everything, not an expert in all of it, but we dabble and we try to get resources for patients that need it. So really, when you come in, you're really family. Like we feel that, and when people text us, we know what's grandma doing, what's your uncle doing, and that is so important to know the whole dynamic of the family to treat correctly. Because if you don't know that huge piece that's going on in their life, you're not. And I feel bad, but in corporate world, corporate medicine, we don't have the time. There's wonderful providers, wonderful people in the corporate healthcare realm and world, but we just don't have. They don't have the time, and that's what's being cut.
100%.
Yeah.
And Rachel, you touched on one piece that I think is hitting so many people, and that is the ability to even find a primary care. So my story, I had a primary care And then I kept getting notices from this practice, like, oh, by the way, so-and-so left, and so you are now assigned to this new physician. And I'd get these letters, they were like serial, like I'd just get them one after another. And so I finally gave up and just didn't have a primary care for a number of years until I found my current provider. And so I think a lot of Maine people are in that same boat. Like, there's so much turnover and churning in this
scary.
practice. Yeah.
And you're certainly not alone. Like, I feel like a lot of
like
patients,
urgent care as my primary care for a long time.
It's so sad, but it's true. That's the way I feel like it's happening right now, which shouldn't be the way of the future, but more direct primary care offices like ours need to pop up and take care of and have access. We have an issue with access, then let's have more direct primary care offices. But
And Rachel, you're working for Live Life Family Practice, but then you're also still in the hospital system and that. And how does that contrast feel to you with, what you're able to offer patients?
Yeah, I mean, I think working in a specialty is a really, the benefit there is that you're often coming in and it's really specialized care, whereas so they're coming to you maybe with more specific problem versus direct primary care, which they were able to help them with their acute needs, but there's also a lot of preventative medicine that takes place. In specialty care, what I'm seeing is that a lot of patients are not coming in with their preventative medicine up to date because their access is so poor. And their ability to get into a provider is just so strained, or they're like you and they've shared the experience where they've maybe had an established provider, but they're getting the notices of that going from one hand to another. And so
there's no continuity.
There's no
lack
continuity.
of continuity.
And as a provider, you feel for them. You want them to have all the care that they deserve, that we deserve, but you're constantly playing catch up.
It is amazing to see these practices developing across the state. What do you say to people who are, frustrated, looking for a practice? Maybe they're in Aroostook County or wherever. How do they start even looking for an independent practice that is?
Question. It is hard because you have to muck through the weeds a little bit, because no one really knows. So we've put a lot of things out there of like accepting. A lot of times too for us, which has been really beneficial, is we go into a lot of small businesses. So across the state, we have a lot of small businesses in our area that come in and their employer pays the monthly fee and their employees are seen. So they don't have to have the crazy marketplace costs of healthcare. Their employees are healthier and their employers are happy because it's a lot less out of their paycheck. So it's a win-win. So we do market a lot to the small town blue collar men and women that are working out there and putting their tails on the line every day and not able to get healthcare because they can't afford the crazy corporate healthcare that's out there.
Yeah.
So that's kind of our world. Is we accept all. We do have patients that come with insurance, and a lot of times they'll use their HSA card or FSA card. So that's kind of a way around it. We're learning. We do labs in the office too, which is a lot cheaper than the hospital setting. So a typical panel of labs are $150, and we do it and draw it right there and send it out. So we try to get a lot of stuff done right in the office for patients, so they're not having to go everywhere. At our newer location, we've got a cool infrared sauna too. We've got 2 mental health counselors, 2 massage therapists, and a dentist.
So
right
like
there, too.
multifocal, like not just nurse practitioner, come see the nurse practitioner, like get your dental care taken care of, make sure it's the holistic, holistic.
And that's our approach, right?
Yeah.
I don't love pharmaceuticals. I think there's a time and place for all, but I'd rather patients go with a more natural lifestyle nutrition route because that's what it all boils down to at the end of the day. So we really try to promote that and really get to the why of the problem instead of putting Band-Aids, because Band-Aids don't last.
Oh my goodness, Band-Aids don't last. And I feel like whether we're talking about healthcare or the state budget or literally any issue, there's so many Band-Aids put in place in various systems. And I refer to Maine, healthcare as crisis care because it really is. You have patients, I remember seeing patients come into the ICU and same thing you're talking about, Rachel, where you're just patching things together and there's not a whole big picture that you're looking at, and you kind of go like, okay, we're going to patch things together for now. but this issue is going to continue to persist. Yeah, it's not actually like holistic healthcare. And I think we're seeing people really want a model where it is looking at the whole person, and there is time with a practitioner to go over everything and make sure that you're hitting on all of it. And I think that's where we're seeing these practices thrive. Where there is a market in Bangor and Southern Maine and everywhere.
I think my experience too is that people really appreciate connection. And so when you do have the handoff from one person to the next, you lose that. It's not anybody's fault. It's just you lose that connection. And I was able with one patient at Live Life to celebrate with her that her daughter was valedictorian. And what a cool experience that was. Right. Just because we were able to have that personal time together to, it extends beyond, just that acute medical, care, but really trying to have a connection with your patients.
I will say, I on social media had posted recently and asked folks about their experience, like with their primary care, how and when they're able to get in, and some people are sharing like these astronomical wait times. It's really incredible, months and months. And Courtney, you mentioned texting, like that's unheard of. Yeah. You're telling me that, like the folks in your practice can text you, and that's just kind of crazy. Right. Because if you are talking to somebody who's using kind of the usual model, they're telling me, I can't get in to see my physician for 2 months when I'm sick.
On hold for half an hour, right? And so when you call us, or most, I would assume, direct primary care models is you call us and you get a human being. So you get our office manager, Robin, which is a love. She's great and can answer a lot of questions. We have a couple nurses. So it's a human being that can kind of help take care of the problem.
Isn't it remarkable that we're talking about this as this is like the exception? Like
I know,
literally people are sick and needing help, and it's the exception, not the rule, that they can actually reach a live person. But that's the direction the healthcare should be going. And what I just want to highlight in this conversation is this is just human beings finding a solution to the healthcare problem that we're facing in our state with inadequate care and high costs, and that is the free market. I mean, this is such a clear example of the free market and what we can do with innovation outside of government assistance / interference, but simply putting a solution out there that clearly people want.
Yeah. And I think our patients really appreciate the transparency. I mean, if there's a question about a cost or one of the things that we offer, you call the office, you get a real person. They can tell you our cost in, a matter of minutes. And it doesn't depend on what coverage you're going to have or what benefits you have. And so people appreciate that. They like to know what their money is going towards and not have to have somebody else decide that for them.
Well, that's such an important piece of the direct patient care model, because we're seeing the opposite in kind of the system where government has its hands in everything. For example, it is a fact that if I were to go to the hospital today, go to the ER, and I use my insurance, I'm not going to be able to find out the cost of that appointment. I'll know how much my copay is, but I'm not going to know that bill until I get it.
And it could be months later.
And it could be months later. And the other piece of that is really awful is that care is being subsidized. So you have government reimbursements are not where they maybe should be. They only cover a certain amount of the care. And so when you have a Maine care patient, that money that the government is reimbursing, the lack of money that they're reimbursing is then getting subsidized by folks who have private insurance or are even paying cash. And so it's a system where you can't know what you're going to have to pay because your dollars are subsidizing other people's care. And it is incredibly unfair. So having that transparency, I think Maine people do want that transparency in how much their care is going to cost that you cannot get in just the system right now.
It's hard. Yeah, and I feel like, you go to any supermarket or any store, right? And you buy an apple, you know what it's going to cost, right? When you go into healthcare, we have no idea. What's that apple? What's that CT? What's the MRI going to cost? We should know that. And we do work with some great companies that we do get care a lot cheaper. So a lot of imaging, we can get it reduced. So we are kind of in the know about all of that, which is awesome too. And I think that's super helpful for our patients to have an idea of what is this going to cost when they come in. And their appointment's half an hour usually, which is unheard of too. Like when they come in, they're like, wait, I get an hour to talk to you? Like, yeah, that's how that should be, So I don't know, I feel like we just have it's just a different model than what most of Mainers I think are used to, but I think it's popping up and it's, I'm hoping that more and more do this.
Have you found that your older patients are a little bit more familiar with this model? Like they go, okay, when I was a child, we had care like this.
Like Dr. Quinn, yeah, like they all came to my house. It was great. Yeah, no, it's true. I think it's hard too for over 65, right, with the Medicare, Medicaid of the world.
Sure.
It's really hard because they need to have a provider that accepts that.
Sure.
And unfortunately, we don't accept that. So it's really hard, and they have to make that hard decision, which is really tough for them.
Sure.
Of do I stay and pay, and I'm living paycheck to paycheck, or do I go into the system and not like it? So we've had that happen a few times, and a lot of times they come back because they're like, I'd rather pay and get care than go and just have an unknown. And that changes every couple months of what I'm seeing, which is really hard for them, as well as they have. As we age too, I mean, there's a lot more comorbidities that are happening and things that need to be talked about, and so they just don't have the time.
Yeah.
So I feel like we do a great job of giving them time at Live Life, and also other direct primary cares as well, that we really kind of have that time to talk to and go through that whole list of things they have.
Well, that's when it's so important, right? When you have that whole big long list, that's when you need that consistency over time in your care. And if you're kind of flipping through providers, those things tend to slip through the cracks, and then and that's when things get missed and people get sicker, and that's that crisis care instead of health care.
Right.
Fixing problems instead of band-aiding over.
And someone had once told me too, had asked me, not even told, but had asked me, said, in the perfect world, Courtney, how many patients would you want to see? And I said, 0. Perfect world, 0. They're all taken care of. It's prevention. It's preventative medicine. That's what we all went into. Like,
yes,
it makes me upset, but it's like, we all did this, like prevention. And right now, but it's chronic disease management. It's so sad. Sorry.
That's okay.
Yeah.
It's nice to see providers who care and, who want to see a world where people aren't just kind of ill.
Yeah, we want
Like
prevention.
living in a world where people are just like accepting that we're all kind of sick.
We all are. We go on a whole nother topic of
Yeah.
that. But so we really try to advocate for prevention of let's take care of you. Let's get the right things done. We'll figure out the cost, but you are important. And that's what people need to know.
Yeah. This really hit home for me when I was working in the ICU. Yeah. When I was in high school, I worked I worked at a local restaurant. It shall not be named. It was a wonderful experience. I loved my job. But the food was not the healthiest, right? We all know that. You don't go to a restaurant for healthy food generally. And so as I was going through nursing school, I kind of thought I wonder if I'll ever see any of my, the folks I served, because we'd have regulars, right? You had regulars who were there all the time. And lo and behold, at one point working in the ICU, I did indeed, unfortunately, have a gentleman. He came in tremendously ill and died there in the ICU. And I remember thinking, I remember serving you at this restaurant and thinking this is, I know this gentleman has just this unhealthy lifestyle, wants to live a really full life, but maybe doesn't know how to have good habits, and kind of saw that come full circle. And so I love how passionate you are about making sure that it is prevention and that we're treating the whole person. And isn't that what direct primary care is really geared towards and all about?
That's what we try to do. I feel like we both are, and a lot of it's about teaching, right? We're just uneducated about what foods, what toxins, all the things that are going in our system that we just don't have the time to talk about in regular everyday. So I think we really do. Rachel's a great teacher. I mean, I've learned a lot from her already, just from women's health stuff, which is great, and vice versa. But I think we really do a great job as a team to kind of tackle that problem of teaching and educating and putting information out there so people can have it.
Okay. I love that.
Yeah.
I love that so much because that's what we're about, on the political spectrum here at Lead Maine is we believe we are where we are as a state because folks don't know. They don't know how the government that's closest to us affects us the most, the care that's closest to us affects us the most. And we are just absolutely on a mission to educate Maine people about how the things that are done in Augusta, the bills that are passed, the laws that come to be, are affecting literally our daily lives so much more than we ever understand. Just like, the health care or lack of health care and the habits, the daily habits that you have impact that long term so tremendously. I know we didn't plant that, but that works in so perfectly.
Yeah, exactly.
So what we're doing here. Yeah.
No, we're pretty lucky. I mean, we're super excited to move to Poland, so it'll kind of be a better location for access of care from Lewis and Auburn area, Great New Gloucester, Portland. Right now we're up in South Paris, and it's been an awesome location. We've had great patients, love our patients.
Okay, so let me ask though, you're in South Paris, there are a limited number of these direct primary care practices in the state at this point. It's growing, which is amazing to see. How far? I mean, do you have patients who come from pretty far away to come to South Paris?
I mean, I think we have some up in China, Maine that come to see us.
Okay.
I'm trying to think of where
How
else.
much of a hike is that?
I know, it's probably at least it's over an hour.
Over an hour.
Over an hour, I would say.
Okay.
At least hour and a half
Wow.
for some of them. I've got a patient that comes from Northport, Maine, so
Wow.
far. Yeah.
Yes.
But they usually come a couple times a year, and they know that they can access our care. So
Yeah.
even if we don't see patients, we can have a telephone call, we can text them, you can, email. So we have a lot of access to our care, even if it's not in person, which is really kind of nice too.
Yeah, that's amazing. I think it just shows the appetite for more of this type of care across the state when you have patients who are willing to travel like that. And I think there are probably so many people who don't know that this care is available across the state, that these practices are opening. And so it's been exciting to read a little bit more about it, kind of seeing that pop up in the mainstream. Because I think once you hit that, that's kind of critical mass, right? And folks start learning more and more about what is possible.
We hope it pops up. I would love to see it as a specialty care. Wouldn't it be awesome to have a rheumatologist that has his own DPC?
Oh, that would be amazing.
Or direct care kind of model.
Yes.
Wouldn't it be great for ortho to have their own place instead of tied to the hospital? So I would love to see it in specialty care because it's really hard to get access to that as well.
Absolutely.
We do our best to get patients in where we can and as quick as we can. But again, it's the lack of awesome providers, awesome doctors, NPs, physicians, just lack of the hospital system is very difficult as well.
Do you have any kind of final words you would say to folks who are frustrated with their healthcare system, wherever they may be in Maine, across the country? What direction should we be moving? Obviously, direct patient care.
Come see us and live life, right? Come see us and live life in my practice. No, but also just direct primary care. Just know your options. Look out. Ask. A lot of the town boards, I guess, or schools. A lot of times we post in there. Trying to think of other places.
I think the big word that comes to mind for me is advocate. If you feel like if you need something and you're not getting it, you need to advocate. We used to say the squeaky wheel gets the grease, and I think that's so true. I think unfortunately we're so used to maybe being put on the back burner, or we're used to the phone triage.
That just becomes normal.
It becomes the norm.
So you're like, okay,
it's the norm.
I'll get my phone call back, 48 hours from now, and that's normal.
Yeah.
So I'll just kind of let that be.
ER at that point. It's sad but true.
But I think if you want that connection with a provider, they're there. There's great providers across all avenues of Maine healthcare. I think that you just have to advocate. If you're not getting what you need, you have to make sure that you're getting that wheel greased. Yeah.
Well, that's great advice, Rachel. Thank you both so much for coming in to talk with
Thanks
us.
for having us. This is
My
great.
pleasure.
Awesome. Thank you.